Methotrexate is one of the most widely used anti-cancer drugs. Over the next few minutes, I'll review information about this drug that should be considered with its administration. Methotrexate is a cell cycle-specific antimetabolite. Working in the S phase, methotrexate inhibits the enzyme dehydrofolate reductase, or DHFR, resulting in the inhibition of DNA, RNA, and protein synthesis. It is a folic acid antagonist, essentially altering the body's use of folic acid needed for cell growth. The drug is used for many oncology and non-oncology indications. It is FDA approved for several cancers, including ALL, meningeal leukemia, lung, breast, head and neck cancers, mycosis fungoides, and non-Hodgkin's lymphoma. There's also indications for non-oncology conditions, such as rheumatoid arthritis, juvenile RA, juvenile idiopathic arthritis, psoriasis, and psoriatic arthritis. The literature notes many uses that do not currently have FDA approval. These include multiple sclerosis, lupus, active Crohn's disease, ulcerative colitis, ectopic pregnancy, sarcoidosis, dermatomyositis, polymyositis, and post-organ transplant. Methotrexate has multiple routes, and the dosage schedule may vary considerably, so it's important to use caution when you're calculating and verifying the dose. Routes include oral, intravenous, subcutaneous, intramuscular, intrathecal, and intraarterial. It is neither an irritant nor a vesicant. The side effects of methotrexate are dose dependent, and this slide lists the most common toxicities. The drug is primarily cleared through the kidneys, with 80 to 90% of the drug excreted unchanged in the urine. Therefore, any impairment in the glomerular filtration rate will result in sustained serum levels of the drug, and this can increase toxicities. Myelosuppression usually appears within 3 to 7 days, and it usually resolves within 2 weeks. At lower doses, the risk of nausea and vomiting is minimal or low, but moderate with higher doses. Photosensitivity is common, and you may also see some reddening of the skin or a rash. There are a number of nursing considerations you should keep in mind when caring for those receiving methotrexate. First, it's yellow in color, so you won't be surprised when it comes up from the pharmacy. There's a large range of dose amounts. Low doses, such as when you treat RA or psoriasis, might be up to 20 milligrams per meter squared per week. High doses in comparison may be 1 gram to 12 grams as a normal dose, and it can go even higher than that. It's important to check the kidney function prior to administering methotrexate and to avoid drugs that can be kidney toxic. Also ensure that your patient remains well hydrated, having 2 to 3 liters per day of fluid intake. There are multiple drug interactions that can happen with methotrexate. These can include nonsteroidals, aspirin, warfarin, aminoglycosides, and medication reconciliation is very important. Oral mucositis can be significant, especially at the higher doses. Instruct your patient in good oral hygiene. And because hepatotoxicity that can occur with methotrexate, alcohol consumption is discouraged. Oncology patients and women receiving methotrexate for ectopic pregnancy should avoid taking folic acid, because this will block the action of the methotrexate. Check multivitamins to ensure that there's no folic acid in the tablet. However, when used for non-malignant purposes, folic acid doesn't seem to decrease the anti-inflammatory activity of methotrexate, and it may be used to minimize side effects. Teach your patients to follow photosensitivity precautions using a sunscreen with an SPF of at least 15 during sunlight exposure. Methotrexate is contraindicated in patients with pleural and pericardial infusions and ascites because of the severe toxicity from methotrexate accumulation. Careful monitoring is essential when methotrexate is given at high doses, which are doses greater than 1 gram per meter squared. High-dose methotrexate doses are adjusted for renal dysfunction, so it's important to monitor creatinine levels. To prevent renal damage, high doses of methotrexate must be followed by timely administration of leucovorin and alkaline hydration. It's important to have concurrent orders for the leucovorin and hydration when high-dose methotrexate orders are written. Calcium leucovorin is a derivative of folic acid, and when given at specific intervals, it competes with methotrexate's ability to enter the cell and rescues the cells from the methotrexate toxicity. Depending on the regimen, it started between 24 to 36 hours after methotrexate administration and must be given on time. Vigorous alkaline hydration will enhance the solubility of methotrexate in the urine. Monitor the pH of the urine to keep it between 7 and 8.5. Consider monitoring the CO2 levels during IV alkalization, though, to prevent metabolic or respiratory alkalosis. Strict intake and output measurements are needed to monitor the urine output closely to avoid a negative fluid balance. It's also important to avoid any nephrotoxic medications such as nonsteroidals. You will also monitor the serum methotrexate level and the creatinine. Monitor your serum methotrexate levels until they reach below or equal to 0.1 micromole per liter. You'll monitor both the blood levels of methotrexate and the urine pH until it reaches that point. Now, depending on methotrexate clearance, some patients may require additional leucovorin rescue and serum methotrexate monitoring. It's not too unusual. There is a drug called glucarpidase. It's a medication that is FDA approved for patients with delayed methotrexate clearance due to renal impairment. The drug reduces the systemic methotrexate levels by rapidly converting it to other substances which can be cleared from the body. And here are some additional references if you're looking for more information. Thank you very much for your time.